In a country racing toward a trillion-dollar economy, the skyline tells a story of limitless growth. But at the base of these glass towers, millions fight for basic survival. The morning starts with the heavy, damp air of a cramped room and the persistent cough of a child waking up under a makeshift net. The United Nations defines a slum by the absence of durable housing, sufficient living space, safe water, and adequate sanitation. The rapid expanse of cities like Mumbai and Delhi relies entirely on the people living here, a massive informal workforce pushed into the narrowest margins of the map. To understand why people get sick in these margins, we have to look past simple biology. In public health, a medico-social lens recognizes that human health is dictated by the physical environment, education, and income. Here, the environment itself acts as the underlying condition. Long before anyone goes to work, there is an immediate battle for survival. Water is scarce. Families wash clothes and dishes directly over heavy accumulations of garbage, and navigating open defecation remains a daily reality. When thousands of makeshift homes are packed together with no green space or formal zoning, the neighborhood becomes a highly efficient incubator for pathogens. Dwellings sit inches away from dark, stagnant canals. Living in constant, direct proximity to this polluted water drives severe gastrointestinal illnesses and recurrent respiratory infections. Before a resident even steps out for a day of hard labor, the built infrastructure has already subjected their body to an active public health crisis. The risks multiply during working hours. The informal jobs available to these residents offer volatile daily wages, leading directly to chronic food insecurity and dangerous occupational hazards. This disease cycle starts with malnutrition from volatile wages, lowering immunity. Combined with extreme overcrowding, infections like tuberculosis spread rapidly. Sick workers cannot earn their daily wage. This income loss deepens food insecurity, looping back to the beginning. Falling ill in these conditions is a mathematically predictable outcome, engineered by spatial and economic neglect. When sickness strikes a child, parents face a terrifying reality. There is often a complete vacuum of formal primary healthcare clinics inside the settlement itself. The National Health Mission deploys ASHA workers, the women in pink you see here, engaging directly with the community. They act as the frontline defense, but they are severely overburdened by the sheer volume of patients. Desperate, time-poor families need immediate relief. They turn to unregulated, informal practitioners operating within the slum simply because they are accessible right then and there. But these workarounds often fail. When symptoms escalate, families are forced to abandon their shifts, forfeit their wages entirely, and travel far outside the neighborhood for help. They arrive at the overburdened public hospital system as an absolute last resort. This image shows the overwhelming reality of that system, a staggering density of patients waiting for hours just to be seen by a doctor. Instead of providing a safety net, the healthcare system actively penalizes the poor, draining their lost wages and driving them into deeper debt just for seeking help. Beyond the macro statistics, families face deeply intimate dilemmas. A mother looks at a handful of coins and makes an impossible calculation: buy enough food to get her family through the day, or buy the antibiotics to treat her child's infection. That mother makes her choice in a neighborhood suffering from severe malnutrition, while the billboards overhead are blanketed with aggressive advertising for cheap, processed junk food. Endless capital pours into constructing the towering commercial developments that loom over these informal settlements. Yet, the basic infrastructure below, clean water lines, sewage, clinics, is chronically and intentionally neglected. Policymakers treat this widening gap in health outcomes as an acceptable cost of the economic boom. We already have the tools to address this. The solutions are highly scalable: empowering and funding more ASHA workers, investing in localized community interventions like direct nutritional guidance, and expanding robust urban health missions. Implementing these public-private partnerships depends entirely on reallocating political priorities, rather than discovering new medical breakthroughs. Allowing a generational health collapse in the urban margins eventually hollows out the foundation of the entire city's workforce. The engine of the economy cannot run on a sick population. The medico-social collapse within these slums